from the time of British days till now, and we have kept on the system. So although we do have two parallel public and private health systems which are independent of each other, by definition all Malaysians have got universal health coverage in the public health system. And it is a system which is funded wholly by taxation, and the good socio-economic situation of the country allowed it to be sustainable till now, and it has done well because we inherited a very good network of primary care setup from independence, and we have developed upon this. And at the present moment, initially we had a three-tier primary care system of main health centers. For each one main health center, we used to have 4 health sub-centers, and under the sub-centers, 20 midwife clinics for every 50,000 rural people. And since then, we have restructured it to a 2-tier system with a health center which serves 15,000 to 20,000 rural population, and a community clinic which serves 4,000 population. And 90% of Malaysia's population have got a health facility within 5 kilometers of their residence. And this provision is of course subsidized by the government public system. And as time evolved from primary care, we started having secondary and tertiary care, and we continue to do so. And this has shown us results in that infant mortality rate dropped from 75 per 1,000 live births in 1957 to 17.5 in 1984 and to 6.6 in 2011. And maternal mortality rate fell from 200 in 1957 when we got independence to 25.5 in 2011. And life expectancy, which was less than 60 in 1957, is at present 73 for females, 73 for males, and 77 for females at the present time. So all these are the good stories, and of course it's a system which is running and providing medical care for the people, and the Malaysians generally have a very high level of financial risk protection because in the public system they only pay nominal fees. 98% is subsidized by the government, and so there's very low frequency of catastrophic health expenditure amongst Malaysians. 74% of the households use less than 1% of their total household expenditure for health, and so this is all the good stories. But it's got its challenges. It's got its challenges, and because as tertiary care particularly becomes more and more expensive and more technology based, and as we give the expectation to the public to expect that level of care, this poses great strain and stress on the health system. So we have to deal with that. And of course we have our share of problems as far as, although we do have communicable diseases, but our greater threat from non-communicable diseases is high. Prevalence of diabetes is increased from 14.9% in 2006 to 20% in 2011, and we think maybe another 10% which is undiagnosed. So that shows us the potential problems which we have in terms of dealing with NCDs and an increasing aging population. And the other thing, of course, as I alluded to just now, we have two systems which are on parallel. One is the public system, which is completely funded by the state, and there's a private system which is more or less completely funded by the individual or the employers. And in the private system, what is worrying for us is the rate of out-of-pocket payment is very high, and the 77% of payments into the private system is out of pocket. So that is an area of concern. Of course, those who can't afford to go to the private system, then of course they've got to fall back to come back to the public system. That's how it works now. We have people who go and see their preferred consultants in the private and come for medications in the public system. So we have a situation like that which happens, and so this is of course causing stress to us in terms of the government's continued ability to fund this kind of system. So in looking forward, because time does not allow me to go into details, but in looking forward, what we have done now is trying to actually produce greater efficiency and increase productivity into the public system. And this is being done through a renewed emphasis on preventive care and public care, primary care, and try to reduce the need for secondary and tertiary care. And this is done very, very aggressively with greater impetus, particularly after I took over the ministry about 1 year ago. And we are moving towards primary care interventions, which could be outcome-based with delivery of greater KPIs. And we are also looking into strengthening our domiciliary health service and community-based health service to allow decanting of what we call hospital-based treatment to be actually transferred after a critical period into the community and into domiciliary services. For example, if you've got a patient with stroke, and after the acute phase is over, the rehabilitation of the process could be done within the community itself. So that is one way which we are thinking of trying to reduce costs. And the other is, of course, how to maximize utilization of present infrastructure and maximize utilization of present manpower to provide greater efficiency. And we have started a process at re-looking at all processes of delivery as to enhance efficiency and optimization in the process. As we look at it, of course, we are identifying areas of weakness, areas of inefficiency, and areas in which the process can be done much better. So by re-engineering the entire processes and by optimizing the usage, both of manpower and of existing infrastructure, and by putting greater emphasis on primary care, preventive care, and an evolution of both domiciliary and home kind of health services, we hope we can stretch the public dollar to a greater element so that we can actually provide better care. So that is how we are trying to increase efficiency. And of course, the thinking is there whether there should be an attempt of co-sharing of cost. But it's a politically explosive thing in any country in which, of course, there's a human nature. When you give things free and subsequently you start to charge, it becomes an explosive issue. So, in trying to go forward in that, I think it's essential that we have to educate our public to understand, but we have to understand these whole things, so to buy them in before we can actually slowly introduce the idea of cost sharing, so as to ensure long-term sustainability of our health system. Just to give an idea why this might work in Malaysia, our total health expenditure, both private and public, is about 50 billion Malaysian ringgit, out of which about 22 to 23 billion comes from public and about 17 to 18 million comes from private. So there is this capacity of the private to pay. It's just how we are going to be able to create a system in which that capacity of the private sector, the people to contribute to the private sector, that is what we call trying to develop bridges between the two systems to allow cooperation, coexistence, and sharing of resources and responsibility. So that's the direction in which we are trying to go forward. It's not a universal health coverage we have achieved, but the long-term sustainability of the high level of medical care which we have developed, that is our challenge, and we are trying to find the best formula to achieve it. Thank you very much.